So how are we doing this morning? What yeah. Who needs coffee, really?
They copied them. They had copied my presentation.
I think so. It's just.
Then it got deleted.
Let's just
Got to check them.
Is it?
No, it's not it. Yeah. Final question.
This one?
No, this one. Overview.
There we are.
Hello.
Hi.
I made some changes in the first one. Made all this yellow because it was looking dull.
I think we're all good.
There we are.
Great.
So enjoy.
Thank you very much.
Let me
Cheers.
know if anything else happens.
All right.
All good.
Okay, let's see. Shall we get started? I'll just gonna share the screen and hopefully you guys can see this. PowerPoint slide. Can you see this okay?
Yes, brilliant.
Perfect. Okay.
Can I start?
Yeah, go for it. By all means.
Yeah, thanks.
Just check if you can move the screen.
Yeah, check this out.
Try. There you go.
Yes.
Perfect.
Yes. I will do it.
So yes, the camera
So
is.
good for the photo and video, but I'm holding. Okay. Thanks. So now.
This is your camera here, so.
Okay. So can I start? So good morning everybody. So I'm here today to conduct a small workshop on pharmacoeconomics. So the topic is overview of pharmacoeconomic methods with hands-on training. Now the aim is to educate the participants about the concept and methods of pharmacoeconomic evaluation and to provide hands-on training. I'll give some problems so that you can work it out and see how to apply pharmacoeconomic methods and for different treatment options for diseases, taking suitable examples. And at the end of the workshop, participants will be made to understand what is pharmacoeconomics, applications of pharmacoeconomics and health outcomes, then types of healthcare costs with examples and calculation of costs, then different methods of pharmacoeconomic evaluation such as cost minimization, cost effective, cost benefit, and cost utility analysis, then calculation of cost minimization analysis, calculation of cost effectiveness analysis, calculation of incremental cost effectiveness ratio, and cost effective analysis of two anti-diabetic treatments. Then calculation of cost benefit ratio, and you will also understand what is health related quality of life and quality adjusted life years, which are very important for diseases like cancer. And I'll try to show some published articles and we can have a discussion on them. Now coming to the introduction, pharmacoeconomics is a branch of health economics, which evaluates the cost. Cost is expressed in monetary terms and effects. The effects can be expressed in terms of monetary value, efficacy, or enhanced quality of life of a pharmaceutical product. The demand for and cost of health care are increasing worldwide due to sophistication of healthcare technology and cost of medicines. The cost of medicines are increasing constantly, and patients are unable to afford healthcare, especially in developing countries. So there is a need to find optimal therapy at the lowest price. Now, pharmacoeconomics offers different methods that choose the best treatment option, which is most economical without compromising the efficacy. Pharmacoeconomics is a branch of health economics which evaluates and compares the cost and consequences of pharmaceutical products and services. The two major components of pharmacoeconomic evaluation are cost and consequences. Cost is the total value of resource consumed in providing a drug therapy or a service, whereas consequence is the outcome of drug therapy. Now, the healthcare cost is categorized into direct cost, indirect cost, and intangible cost. Under direct cost, you have direct medical cost and non-medical cost. Now, what is direct medical cost? This is what is paid for specialized health resources and services. This includes acquisition cost of medicines, consumables associated with drug administration, cost of hospitalization, physicians' salaries, salaries for healthcare professionals' time and services in preparation and administration of medicines, laboratory costs for monitoring effectiveness as well as monitoring the adverse drug reactions. Whereas direct non-medical cost includes the cost necessary for the patient to receive medical care other than the actual medical cost. These costs involve resources that are not directly consumed during the provision of service, but without which the provision of service would not be possible, like lodging, transportation charges, special diet, and so on. Indirect costs relate to any losses incurred to society as a result of the disease and treatment. This is the cost incurred by the patient, family, friends, or society. Now, many of these are difficult to measure, but they should be of concern to the society as a whole, which includes because there is loss of productivity from a disease, and this can affect the patient, his family, and the society. Then caregivers will be there who are not paid. Then lost wages or salaries due to the disease. Then expenses of illness borne by the patients, relatives, friends, employers, and the government. Then the loss of leisure time and resignation of the jobs due to inability to work. Now, intangible costs are the costs related with the non-financial outcome of the disease and medical care, which cannot be expressed by money. Like the patient's anxiety, pain, and suffering, we cannot explain in terms of money. Then worry and other distress of the family members of the patient. Then the effect on the quality of life of the patient resulting from the illness, poor health, and the treatment. For example, patients of rheumatoid arthritis, cancer, or having terminal illnesses in which the quality of life is affected due to adverse reactions of the drug treatment. Now let's see the calculation of costs. Calculation of the direct cost, we need, as I told you earlier, we need to calculate, we need to put the values for all this, like the physician and support staff salaries, medical supplies cost, lab tests, and any other resources consumed at the time of service, like oxygen and all that. So you add up all that, and that will be the total cost. And calculation of the non-medical cost would be, suppose the patient is taking a treatment for 1 week, let us say, in a hospital. So what would be the accommodation charges? What would be the transportation from the accommodation to the hospital for that 1 week? And what are the food charges? So all the expenses that are incurred in the patient coming to the hospital and taking the treatment, add them up all together, and that will be the total cost. Then health outcome measures the change in health status of an individual due to the intervention. And typical health outcomes include the cure rate, that is the percentage, the percent cured of illness, improved quality of life, decreased incidence of morbidity, years of extended life in case of diseases like cancer, which are in the last stages, then relief or reduction in the symptoms, like in case of rheumatoid arthritis, then therapeutic failure, adverse events, and mortality. Now we call it as ECO model, that is economic, clinical, humanistic outcomes. See, what are the clinical outcomes? The clinical outcomes are efficacy, safety, and adverse effects. The economic outcomes are work productivity, direct medical cost, and resources consumed. And humanistic outcomes include satisfaction, tolerability, and quality of life. Now let's go to the first method, that is the cost minimization analysis. Now this method is used to compare the outcomes of 2 or more therapies that are equivalent in therapeutic effects. Like let us say you have 2 or 3 different brands of the same medicine, or any 2 products which are having the similar therapeutic effects you can take. So this method is the one that is most often used by DTC to compare different drugs and treatment interventions. Suppose you have 2-3 analgesics. So which one to include in the formulary? So the DTC has to decide that, and they can use this method to decide. So the method to perform is obtain the acquisition price of the drugs, calculate the physician cost, calculate the pharmacy nursing cost and administration of the dosage, what are the costs, calculate the cost of any ancillary equipments that include syringes, needles, IV sets, sterile water, and so on, calculate the cost of laboratory services, calculate the cost of any other significant factors such as oxygen cylinder. So now I've taken an example of 2 injectable antibiotics for treating meningitis. So you can see this is drug A and drug B. So acquisition cost of drug A is $8 and that of B is $15. So if you just look at the acquisition price, drug B looks with higher price than A, because this is 15 and this is 8. But we cannot just decide which is better or which is cheaper by just looking at the acquisition price of the drug. We have to look at all the other factors also. So let's put the other factors. The pharmacist salary, here in this case it is 2.5, 1.5. Nursing salary 2.5, 2. Supplies 9, 2.25. Lab services $4, $1. So if you total, this will be 26 and this is 21.75. So if you look in totality, drug B is 21, it's costing you $21.75 versus drug A, which is 26. So drug B is more economical actually. But if you only look at the acquisition price, it looks like drug A is more economical. So we need to calculate in total the cost of treatment and then make a decision. So completing the CMA provides information indicating the real cost of the 2 drugs is the whole cost of therapy is significantly different from the only acquisition price. So now I've taken another example of just to make you all understand better. Cost minimization analysis of pre-injectable narcotic analgesics. Just have a look. So you have diamorphin, a 5 milligram vial, you have pethidine, as well as you have pentazocine. So now what are the various costs? Recommended treatment regimen is given here, 5 milligrams 4-hourly, 5 milligram 4-hourly IM or SC. So we have given the recommended treatment regimen. So acquisition price is given for all. Number of doses needed per day is also given. Price for 1-day treatment is given. Then the nursing salary for slow injection, syringe plus needle, and so on. So when you add all this, for this, it is costing you for the total drug cost per day in USD. This is 47.04. This is 35.04. This is 28.98. This is 39.66. So when we have to make a choice between these, pethidine 50 milligram vial, that is IM or SC, which is this is costing the least, 28.98. All of them are having similar effectiveness. There is no compromise on that. So then, keeping that as a constant factor, that which is most economical is the preferred one. So in this case, pethidine IM or SC is the cheapest option. And diamorphin given by slow IV is the most expensive option. So this is how we calculate. So one activity I have just kept for the participants. So PTC of the hospital has to select an antibiotic for treating meningitis in children. There are 3 antibiotics which are proven to be equally effective. Which one should the PTC select based upon the CMA? So if anyone, would you want to work it out? Because I have, this is a hands-on workshop. So if you're interested, you can work it out. So this is ceftriaxone injection. This is the dose. This is ampicillin. This is cefatoxime. So I have given the details and other administration cost. I've also given the pharmacist salary. Then I can show you the thing, but if you, I'll give you 5 minutes if you would like to work it out.
We have all the costs.
Yeah. So if they want to work it out, because it's hands-on,
Yep.
so that will help them. Is there a pen so that I can also write on the board? There is duster is there. Yeah. Oh, this, I want this.
Okay, perfect.
Yeah.
Okay.
See, we can first take the cost of the drug. The cost of the drug is, see, dose is 1 gram IV every 24 hours. That means the dose per day is 1 gram. So 1 dose is costing 56.6. And treatment course is 7 days. So you can just write down this. It's very interesting if you work it out. So cost of drug would be 7 because per dose it is 56.6. 56.6 into 7 it will be. See, 56.7 into 7. So cost of the medicine would be, in the first case, 396.2. Okay. Then IV set is costing 5.6 rupees. IV set. So IV set will be replaced every 3 days. So he's there in the hospital for 7 days. So 3 sets we can take, assume. So 5.6 into 3. That is 16.8. Yeah, no, here, first I have given the cost of medicines, right? I have given the cost of all. Yeah, I'll show you. This is the cost of the first medicine, cost of second medicine, cost of third medicine. Then I have given other administration cost because we need to include those also now while calculating. So I have given the IV set cost, then the nursing salary also I have given to prepare and administer 1 dose of the antibiotic I have given. Then I have given pharmacy salary also. For this drug, what it is, for this drug, what it is, for this drug, what it is. So you can write down. Now I will not disturb. Yeah. I just wanted to explain. Yes, I will show the next slide. Yes. So after giving the cost of treatment, I gave the others. Shall I go to the next slide? You're writing down, huh? Okay, thank you. Next, shall I go to the next? So to calculate the total cost of treatment, all the.
Let's just put this way a little bit.
Okay.
Take it to the board.
Yeah, okay. Duration of treatment is 7 days. So we need to calculate for drug A, what it is, B, what it is, C, what it is. Once you work out, I'll give the result. Yeah, this is the result. If you have any doubts, you can ask me. So all the three are used for treating meningitis. The question is, which one is the most economical option? This is given once a day. So 1 dose into 7 days. This one. And IV set will be replaced every 3 days. So I have taken 3 IV sets. And the nursing salary is per dose it is 75 into 7 days it is 525. And pharmacist salary is 150 per day. So 150 into 7 this. So we need to total everything. For 7 days, the total cost of therapy is 1,988 rupees for ceftriaxone. So what about ampicillin? We'll have to look at the dose. Ampicillin is given every 4 hours. So every 4 hours if it is given, into 6. In 24 hours, 6 doses are given. So 10 into 6 per day. And for 7 days, it is 10 into 6 into 7. That is 420 rupees. Then IV set again replaced every 3 days, so 16.8. Then 450 is nursing salary, because I've given here the nursing salary. To prepare 1 dose is 75, but here he has to prepare 6 doses a day. So 75 into that will give you 450 rupees. Then pharmacist salary is 50 into 6 into 7, 2,100. So 5,686 rupees. So similarly, ceftriaxone. So it is given every 12 hours. So in a day, 2 doses are given. So 36 into 2 doses per day for 7 days into 7. So 504. Then IV sets will be replaced every 3 days. So 5.6 into 3, 16.8. Then nursing salary. To administer 1 dose is 75. But here 2 doses per day. So 75 into 2 is 150. And for 7 days in a week, that treatment 150 into 7, 1,050. Then pharmacist salary I've given here. But it's 100 rupees to prepare 1 dose of antibiotic. So per day we have 2 doses of antibiotic. So 100 into 2 into 7 for 7 days. So 1,400. So 2,970. So like this we need to calculate. Bottom line is we need to calculate the cost of everything. Suppose the treatment the duration is 7 days or 10 days or whatever it is, we need to calculate the cost of the medicine for the entire duration of the therapy. For 7 days what it is, for 10 days what it is. So it is the total of cost of medicine plus cost of the equipments like IV, oxygen and other things, the nursing salary, the pharmacist salary, if there is physician salary which is not there in this, that also has to be added. Also add everything and then total it. And then see which is the least expensive. Because all the 3 can be used to treat meningitis. So which one is the preferred one? So here the answer is this is 1,988, this is 5,686, this is 2,970. So obviously ceftriaxone injection is the most economical option. But if you just look at its price, no, this is costing you 56.6. This is costing 10 rupees. This is costing 36 rupees. If you just look at the only the individual price of the medicine, 1 dose, ceftriaxone looks expensive compared to the 3. But actually, if you calculate everything, no, ceftriaxone is the cheaper option. So that is why we need to calculate all the things and then decide the most economical option. So this is how we calculate using the cost minimization. And this is just one published article. Yeah. Maybe later on you can see this. There are many published articles This is a published article on cost minimization analysis of capecitabine versus 5-fluorouracil based treatment for gastric cancer patients in Hong Kong. So they have worked out and they have this is a full length article is there. Many articles are there. Like this, you can take the full length also.
Like a standard cost for pharmacists to administer these things, like is it like for an intramuscular injection with this is how many dollars pharmacists or is it you know for medication so that one there might be extra preparation involved or there might be
Yeah, like there may be for one dose you may be charging something. There is an extra preparation. Suppose there is no extra preparation per day, whatever you charging. For something there may be extra preparation, like absorbing the water for injection or something like that. So all that should be included.
at the beginning of the study they were trying to figure out how long it would take to prepare these things.
Yeah. All that that should be added. Suppose we take 1 hour for 1 hour dismissal fees or dismissal dollars, if he is using some techniques to dissolve the medicine and all that, then whatever cost is involved by the pharmacist, whatever the hospital pays the pharmacist, you know, to prepare that should be added.
So it's sort of an individualized thing rather than just a standard.
Yeah, that
This
is
is how
true,
much
yeah.
we charge.
True. Because for one drug, it may be there is special preparation. For other drug, it may not be. True. Individually, we have to decide. That's right. You got it. I want to go back to the slide. Where is my? Here, yes, thank God I got now. Yeah. That was the first method. The second method is cost effectiveness analysis. This is okay. Why it got? I'm sorry. So that this one has gone. Where is the intention? This is all. This is not sharing, huh? It stopped. Sir, it has stopped sharing, it is telling. I just want to confirm. Because that photo stopped. Cost minimization, you understood, huh? Adding everything. That is cost minimization. What is it? So this is, yeah. So here, cost effectiveness analysis is used when there is a single measurable dimension. Like there are different hypertension for hypertension. There are 3-4 medicines. They are not having the same. What about the So in the cost effectiveness analysis, let us say for hypertension, there are more than 3-4 medicines are there that are having different effectiveness. So which one is having less money, less cost for the same effectiveness? I work out the sum and then you will see. Here the alternative treatments do not have the same effectiveness. Like hypertension, we use blood pressure measurement. For diabetes, we use glycosylated hemoglobin, which we will see. Asthma, incidence of wheezing, pneumonia, cured infections. The alternate treatments do not have the same effectiveness, and it is used when it is necessary to measure clinical outcome of drugs. I think the best is I take out a sum and then I will do. Now, the result of cost effectiveness analysis is expressed as average cost effective ratio, that is called ACER, or incremental cost effective ratio, that is ICER. So what is ACER? Healthcare cost in rupees or dollars divided by the clinical outcome. So we need to calculate cost per unit clinical outcome gained. So looking at this ratio, the clinician can choose that treatment alternative with the least cost per outcome gained. I'll take out a sum and then I will show you. Now, one more formula I'll give you. Incremental cost effective ratio. This gives additional cost required to obtain the additional outcome gained by switching from drug A to drug B. So ICER is equal to cost of A in rupees or dollars minus cost of B in rupees or dollars divided by effect of A in percentage minus effect of B in percentage. Now I'll directly go to the sum. Now just look at this case. This is quite, I mean, this is simple, you can understand. Now patient's name, he is hospitalized for fever and infection, this patient, but he is also diabetic. So the duration of hospitalization was 7 days. And I've just, some simple example has been taken just to explain. So we have just taken the example of, for diabetes, what was he given? He was taking metformin SR 500 milligrams. And per cost, per day cost of metformin 500 milligrams SR was ₹4. So now if you look at the treatment cost, the acquisition charge is 7 into 4, ₹28, because 7 days and per day cost is 4. So for 7 days, it is 7 into 4, 28. Investigation charges is ₹1,050. Room rent 2,800. Physician charge 750. Nursing charge 1,400. Now benefit is when he got admission, his RBS was 173, and during discharge it is 155 milligrams per DL. So benefit is 173 minus 155, that is 18. That means he got the benefit of 18 units. There was a decrease, like for 18 units, it costed 1,400 rupees. So per unit, how much it costed? See, I'll show you.
Sorry, we can't see the slides over here.
What do we? Yeah, that's what I told. Can we call the, I will try to call the computer person.
Okay.
Can you see it now?
Yeah, that's great. Thank you.
Thank you. So for the benefit of 18, it is costing 1,400. So for one, per unit benefit, what does it cost? So 1,400 divided by 18. So total treat, that's what it means. Total treatment cost is 1,400. Benefit is 18. So we need to calculate that. That is the average cost effectiveness ratio. Now this is how I have worked out. See, I have worked it out. So total treatment cost, I've added everything. ₹6,028. Benefit is 18. So cost effectiveness ratio is 6028 divided by 18, it is 334 rupees, 334.89 rupees it is costing for unit reduction in the RBS value. Let's see the other case. Can you work out this? Please work out this and let me know what is the cost effectiveness ratio. Calculate the total treatment cost. They were not able to see the slides.
Not able.
Now they said they can see. There was some issue.
No, they can see us.
Now they can see. No, that time he rectified. Thank you for that.
It's just that we shrank it down.
Okay. Thank you. So please add all the charges: acquisition plus investigation plus room rent plus physician charge plus nursing charge. Add everything. That will be the total treatment cost. And benefit is, at the while admission it was 240. Later it became 163. So the benefit is 240 minus 163, that is 77. Cost effectiveness ratio is total treatment cost divided by 77. Yeah. So you have this is the answer. If you add everything, now total treatment cost would be rupees 6,308. And the benefit is 77. So cost effectiveness ratio is 6308 divided by 77. So 81.92. So this is costing you 81.92. Yeah, so I don't know. 81.92 for unit reduction in the RPS value. Whereas the first one was costing you some 300 rupees. So this is costing 334. See, this was costing you 334 rupees per unit reduction, whereas the second one is costing you 81 rupees, 81.92. So drug B is a cheaper option. I hope you got it, because we're trying to calculate what would be the cost for getting unit reduction in the RBS value. The first one is costing you 300 and odd rupees for unit reduction in the RBS, whereas second drug is costing you 81.92. So obviously, drug B is the more economical option. So this is how we calculate via cost effectiveness analysis. Now you have another problem. Compare drug A and drug B used for the treatment for diabetes using cost effectiveness analysis. You can just, you can work it out. Please take down this. And you can work out this problem.
Interesting about how they come up with that.
This pharmacoeconomics. So it's about the cost. Which treatment option is more economical? How will the hospital go about selecting for inclusion in the formulary? And the next two ones is for the program, like say immunization program. I'll come to that cost benefit. So now the total cost of drug A is 3,500. Drug B is 6,300. So now the problem is, on an average, drug A is found to lower glycosylated hemoglobin by 1.5% and drug B by an average of 0.8%. Now calculate the cost in case of both drug A and drug B for 1% decrease of glycosylated hemoglobin, and which of the two should be recommended to the patient. Actually, I come from India, no? We work in a hospital. So we do a lot of projects in pharmacoeconomics, actually. We have worked on diabetes, hypertension, COPD, asthma. We have worked on many diseases in our hospital. And what we have done is we have taken, for example, asthma, COPD. So we have found out what are the various treatment options in the hospital for asthma. And we have calculated and suggested to the clinician which is the most economical option. So now this is the answer. For 1.5, see, drug A is found to lower by 1.5%. So for 1.5%, it is costing you 3,500. So for 1%, it is how much? It is costing, if you divide 3,500 by 1.5, 2,333 for 1% decrease of glycosylated hemoglobin. That is drug A. And for drug B, 6,300 by 0.8, because it is decreasing by 0.8. It is costing 7,875 for 1% decrease. So obviously, see the difference. This is 2,000 and odd, this is 7,000 odd. So drug A is definitely the one that should be recommended for the patient, because drug A is most economical. This is especially becomes important in developing countries like India, where patients are not able to afford the medication. And there are a number of medications for a disease. For hypertension, there are so many, 10 medications are there. Which one should the patients take? Which one should the hospital have them in the formulary? So these become very, very important, especially in our country, where the patients are not able to afford the medications. Yes.
We do the calculation with the reverse cost there. So drug B costing 3,500, drug A costing 3,300, and we reduced the effect on glycogen.
Drug A is costing this.
No, do the same calculation for the cost.
3,500. We added everything.
That's right.
Yeah.
So say the effect
Yeah.
smaller for the cheaper drug,
Yeah.
but the effect was greater for the more expensive.
Yes. Yes. True.
Then it might come out.
Yeah. So there is another problem which you can do it later. I mean, this is how we consider problems arise. Like your DTC is considering an addition of antibiotic ear drop for the formulary. Now look at this problem. Please look at this problem. Your DTC is considering an addition of an antibiotic ear drop. A is available at the cost of rupees 6.5 for treatment. It's effective in approximately 80% of treatment cases. B has a cost of 7.9 for each treatment and has been found to be 90% effective. The treatment would be used for approximately 1,000 patients each year. So evaluate the cost of these two medications using cost-effective approach. You can do it maybe as a homework. You can take it because I have two more methods to do: cost benefit and cost utility. So you take down this, and you can. It's very interesting. You work it out. I think I have another half an hour, and I have some very important two more methods. I don't want to miss them. This is the I don't know why it is not opening. So this is a case study for where they have used pharmacoeconomic analysis to assess the cost effectiveness of metronidazole. So maybe later on I will try. This is not opening at the moment. We'll see. I'll go to the next method, which is again very interesting. Third method. This is known as the cost benefit analysis. See, as I told you, there is cost and consequence. In the last two methods, cost is expressed as money and consequence is expressed as the response, the effectiveness. But in this case, both the cost and the consequence, both are expressed as money. Means you have to convert the benefit, you have to convert the effectiveness also in terms of money. So we need to compare money versus money in this case. So both the cost and the outcomes are expressed in terms of money. It's a major tool employed to evaluate projects, to determine the feasibility of a project from an economical standpoint. In practice, this is quite complex as it is difficult to calculate all benefits in terms of money. So that is why it is wherever it is possible to convert the benefit into money, we can use it. But everywhere we cannot use this. Because many times everything we can't convert it into money. A person's anxiety we cannot convert to money. So many things are there which we cannot convert to money, isn't it? So wherever possible, it's a very good method for comparing programs. So cost benefit can be applied at a macro level for strategic decisions on healthcare policies like nationwide polio eradication program or immunization program like hepatitis B vaccination program. So for such huge programs, where the state is involved or the country is involved, we can calculate this is the cost of the immunization program and this is the benefit. So is it beneficial to go for this program? I'll show you some sums for that. So here, the cost in resources consumed in conducting the program, outcome is reduced mortality and morbidity that can occur as a result of the program. And the CPA can also be used in examining the value of services like hospital pharmacy-centered IV admixture service. So if a hospital wants to start IV admixture unit, so what is the cost of starting this unit and what would be the benefit of this unit? And is it beneficial? So that can be calculated. Now the CBA equation is cost to benefit ratio is equal to cost in rupees or dollars divided by benefit in rupees or dollars. The net benefit is equal to benefit in rupees or dollars minus cost. Any program with more net benefit is preferred. Alternately, we can also calculate the benefit to cost ratio. If the benefit to cost ratio is more than 1, it means the benefit outweighs the cost and hence such program is of good value. We can implement such a program. If the benefit to cost is 1, it shows that benefit is equal to the cost of providing it. If the benefit to cost ratio is less than 1, it shows that cost of providing outweighs the benefit. So it is not worth going for that program. So when you want to have, I was giving you the example of having that IV unit. in the hospital. The hospital wants to start an IV admixture unit. So what is the cost and what would be the benefit? If the benefit to cost ratio is more than 1, then you can go for it. If it is less than 1, there is no point in going for it because it will incur loss. So other examples of cost benefit analysis are evaluating coronary risk factor reduction program, childhood immunization program. Then a cost benefit analysis of a cardiovascular disease prevention trial using folate supplementation was published in American Journal of Public Health in Jan 1998. And economic evaluation has become an integral component of health service research. Here, the effects of treatment, complication, number of disability days, and number of life years gained, all should be converted into cost. So now you can just see, if a service costs ₹1,000 to implement, and the results in a benefit of ₹10,000 to the hospital, the benefit to cost ratio is 10. If another service costs 25 lakhs to implement, and it results in a benefit of ₹2.5 crores to the hospital, even then the benefit to cost ratio is 10. So in the first case it is, so you can see cost to start 10,000, benefit at the end of first year 15,000, benefit to cost ratio 1.5:1. B, cost to start 100,000, benefit 180,000, benefit to cost ratio 1.5:1. So now this is having greater benefit, no, 1.8:1. Program B has a greater benefit. And in general, the benefit to cost ratio is more than 1, so it's beneficial. And between the two, this is more beneficial. Now, there are two methods of assessing the consequence of treatment in monetary terms. One is called the human capital approach. Now, this method is based on the fact that, of course, this is not like valid by everybody, but this is how the hypothesis is. It is based on the fact that humans are similar to pieces of equipments and are expected to form a product or activity in some monetary value in future years. The value of activity over a period of time is assumed to be equal to individuals' salary. Now, the benefits of healthcare can be measured in terms of future income that would have been lost due to ill health. Like, how do we calculate in terms of money? I'm telling. I mean, you need to calculate what would be the loss if at all, say, if a disease comes and he's not able to go for work for 6 months, then his salary into 6 months. So this much money is the loss. Using a technique called time discounting, the amount of money foregone is adjusted according to the number of years over which it would have been expected to accumulate. This eliminates the influence of time. Now, the human capital approach places monetary value on human life. And in the past, ethical objections have been raised. And in addition, using an individual salary as a measure of value may not be valid because all of them may not be working. There may be some people who are not working also. Then what to do about them? So like this, there are some questions. Salary only relates to productivity and benefits, which do not necessarily result in payment. There is no measure of the benefits of not having to actually go for work or the benefits of reduced pain and suffering due to illness. So that there is a lot of controversies and questions for that first method. Second method is willingness to pay approach. With the willingness to pay approach, observations or stated preferences of individuals are used to value benefits. Now, using interviews or questionnaires, subjects are asked how much they would be prepared to pay in order to obtain the benefits of a treatment or to avoid the cost of ill health. For example, an opening bid is made which the subject can accept or reject. Thereafter, bids are either raised or lowered until the subject's maximum willingness to pay is reached. The starting point of the bidding process may, however, influence the subject while making choices, and therefore the interviewer needs to use discrete questions. The subject is often presented with a series of prizes and is asked to offer a yes or no answer depending on their willingness to pay. Now, problems may arise here because the amount different people are willing to pay for a benefit is variable and influenced by their income. There is also the issue of who judges the willingness to pay. So please work out this problem, cost benefit analysis. You can work this out. So just like the previous case, cost of the drug A treatment would be acquisition cost, administration cost, monitoring, adverse effects, etc. It is coming to $500, and benefits, days at work calculated as $1,000, extra months of life calculated in terms of money as 2,000. So this is 3,000. So benefit to cost ratio. Benefit to cost. Benefit to cost ratio, not risk. Benefit to cost ratio is 1,000 divided by 500. It is 6:1. This is how we calculate. So the limitations of this method is it may be difficult to always measure outcomes in terms of currency. And unless outcomes are appropriately expressed in terms of money, we should not apply this method. It is controversial tool as it tags monetary values for everything, even for which we cannot assign monetary value. The applications are, with this technique, we can compare non-drug program with a drug program, healthcare program with a non-healthcare program. And it's one of the best tools to allocate resources for the public programs. I was telling you polio eradication program. So if you want to allocate funds, is it worth allocating? Is a benefit to cost ratio more than 1? If it is so, then they allocate. The state or the central government allocates the funds. So, and CBE also helps to choose the treatment option in the hospital where the benefit outweighs the cost. So it is used both in micro as well as macro settings. There are many examples. Let's see if this opens. There are many published articles. I don't know why this site reported request is not valid. So anyway, there is an example of the case study. Please, you can take a photograph of this site and then you can go through this. This is a cost benefit analysis of monitoring serum vancomycin concentration in a teaching hospital. I have another 15 minutes. So this is an interesting paper. You can have a look. Even this also, you please take a photograph. Cost benefit analysis of support program for nursing staff. They want to have a support program and whether it is worth it, whether it is beneficial. Some calculations are done. Now we have come to the last method, fourth method, last method, that is known as the cost utility analysis. Now here the interesting thing is the cost and the consequence. So previously the cost is always in terms of money and consequences in the first case also was response, cost minimization. Here also it was effectiveness. Third case, it was money. Here it is humanistic outcomes. Humanistic outcomes. That means in terms of the outcome is measured in terms of quality of life. This is used in those cases where there may not be full treatment in the sense there is no cure for diseases like end stage renal problem or last stage of cancer and all that. There is no cure. However, when there are more than one treatment option, there are 3-4 treatment options. Which method is providing a better quality of life? Or which method is giving more extended years of life? From 2-3 more years it is giving life. So such a method is chosen, which is most economical. So this compares the cost of different procedures with their outcomes. And here we have this quality of life that is coming in. So quality of life refers to the person's perception regarding his physical and mental well-being. And this cost utility analysis evaluates the impact of disease and the treatment of the disease on patients' health-related quality of life, we call. So what is this HRQOL? Health-related quality of life. This is a multidimensional concept that refers to a person's total well-being, including domains related to physical, mental, emotional, and social functioning. The commonly measured parameters include physical health, mental health, emotional health, and social health. In the case of disease conditions with shorter life expectancy and for which there is no cure, managing symptoms and maintaining function and well-being should be the main objective of healthcare. So there are specific instruments to measure the health-related quality of life. For example, we have instruments like Arthritis Impact Measurement Scale, Pediatric Functional Independence Measure, Asthma Quality of Life Questionnaire, Diabetes Quality of Life Questionnaire, Kidney Disease Quality of Life, Quality of Life in Epilepsy Patients, Hospital Anxiety and Depression Scale. So like this, there are several scales available. And there is no one group of instrument that will achieve all the potential goals. And then we have one popular instrument that is known as SF36 questionnaire. This is very popular. And this is a general one. This measures physical, mental, all domains in general. This is used in association with a specific instrument. So general instrument gives a measurement of general outcome and allows comparability across the other disease-related conditions. And specific instrument like asthma, health-related quality of life, or anxiety scale and all that is chosen depending on the disease. So coming to the characteristic of the instruments, instrument means the questionnaire that I just gave you the example. It should have validity. That means it refers to the ability of the instrument to measure what is designated to measure. It should be valid. And in the validity, there is content validity and construct validity. Content validity is an assessment of the extent to which the questionnaire covers the range of topics. Like the content should be appropriate. It should cover all topics like physical activity, sexual life, emotions, symptoms, and so on. And construct validity is it's an assessment of the extent to which the results from a given instrument relate to other measures. For example, construct validity of a new test can be assessed in different ways, like measurement of the impact of a treatment. How do we measure the impact of the treatment? That should be there. If the treatment is, let us say, diabetes treatment, So how do we measure? We will either measure the HbA1c values or the fasting sugar values or something like that. So that should be there. That parameter should be there, specifically defined. And the instrument should be reliable. And it should be sensitive. The responsiveness or sensitivity should be there. And interpretability also should be there. So these are the characteristics of a good instrument. Now, what are the outcome measures of CUA? It measures both quality of life in years and quality of life. Now, there is an important term known as quality adjusted life year. QALY it is called as. The preferred treatment alternative is that which costs the lowest per QALY. I want to define what is QALY. See, this is an important slide. Now, the QALY can be calculated using the following formula, which assumes a utility value between 1 and 0. 1 is the perfect health and 0 is death. So the value can range between 0 and 1. So QALY is equal to years of life. That is life years gained into utility value. For example, if a person lives in perfect health for 1 year, so 1 year of life, and then perfect health means 1. Perfect health is 1. So 1 into 1 is 1 QALY. If a person lives in perfect health, so utility value is 1, but he lives only for half a year in perfect health. So 0.5 years of life into 1. So the QALY is 0.5. Conversely, if a person lives for 1 year in a situation with 0.5 utility, that means he's living for 1 year with half of perfect health, then it is 1 year of life into 0.5 utility value. So it is 0.5 QALY. So this is how we calculate. For example, a full year of life in a disease-free patient would be equal 1 QALY, whereas a year spent with a specific disease might be valued significantly lower, perhaps as 0.5, depending on the disease. Now, if a person lives for 3 years with a disease, and the current standard of care for that disease means he or she lives with a utility level of 0.7, then 3 years into 0.7 is 2.1 QALY. If that person takes a new medicine, let's say he takes medicine A, whereby his or her utility level increases to 0.9. It was 0.7, but it became little better because of drug A. That person will have now 2.7 QALY. Therefore, the benefit of the new medicine will be counted as 0.6 QALY because it was 2.7. Now it is, 2.1. Now it is 2.7. So 0.6 is the QALY for drug A. Now, similarly, let's see what is it for drug B. Now, suppose he takes drug B, medicine B. It prolongs the patient's life by 2 years at a utility level of 0.7. Then the new medicine will provide a person with 1.4 additional QALY. So 2 years into 0.7, that is 1.4. So this is providing 0.6. This is providing 1.4. So B is better. B is better because it's providing a greater QALY. So we also calculate what is known as the incremental cost effectiveness ratio. That is the difference in the expected cost of 2 interventions divided by the difference in the expected QALY produced by the 2 interventions. the cost per QALY value of various treatments can be calculated and compared. And this method, cost utility method, is very appropriate to use when you need to compare programs and treatment alternatives that are life extending with major side effects like cancer chemotherapy. And also for those which produce reduction in the morbidity rather than mortality, like treatment of arthritis. There are some examples, like it's also used to study the use of ciprofloxacin and cotrimoxazole in the treatment of acute exacerbation of chronic bronchitis, and even coronary artery bypass graft and the use of erythropoietin in renal failure are totally different procedures. But then we can use this to find out the cost per QALY values of different programs or different interventions for comparing the utility of different programs. So again, there are some case studies published. It is not opening, but you can take the picture of this. So you have some publications you can go through. So cost utility analysis of continuous ambulatory peritoneal dialysis and automated peritoneal dialysis. It's a very good paper. They have shown what would be the cost for this. I have another 5 minutes. Yeah. So coming to the applications, now so far we have seen what is pharmacoeconomics. Then what do you mean by cost? What are the different costs? How to calculate the cost? The 4 different methods of pharmacoeconomics, like cost minimization, cost effectiveness, cost benefit, and cost utility analysis. We have seen the difference between the 4 different methods, and then with some examples we have seen. I hope you got an idea about each method. And now let's see the applications. Now the applied pharmacoeconomics is defined as putting pharmacoeconomic principles, methods, and theories into practice to quantify the value of pharmacy products and pharmaceutical care services in real-world environment. Now, pharmacoeconomics certainly helps in decision-making, as you saw. It helps even an individual doctor to choose a treatment option for a patient, and it helps the hospital also to choose certain medicines for the hospital formulary, as well as it helps the government to choose whether to, go for investment for certain services. So we saw all that. So it helps in decision making, in assessing the affordability of medicines to the patients, and to compare various products for treatment of a disease. It helps to introduce accountability for those which promote a certain type of high-cost medicines. So there are so many high-cost medicines versus generic medicines that the debate is going on. So, there is accountability should be there for those people who promote the high-cost medicines and high-cost services. So this helps to check on those. So because we are not compromising on the effectiveness here, nowhere. So effectiveness will be the same. Keeping the effectiveness same, which is the most affordable method, is what we're looking at. It helps to identify which treatment option represents the best outcome for rupees or dollars. It can provide valuable information to formulary system as well as individual patient treatment decisions. Pharmacoeconomics has use in health policy decisions making about the use of medication and healthcare services, particularly pharmacy services. The tools of pharmacoeconomics can be applied, like the tools means the different methods can be applied by policymakers, primary healthcare providers, healthcare administrators, as well as health managers. There is a publication again where we have an article on the role of pharmacoeconomics in Indian healthcare system. You can take the photograph of this and go through this article also. Yes. So in conclusion, I would say pharmacoeconomic data can be a powerful tool to support various clinical decisions ranging from the micro level, that of the patient, to the entire healthcare system, that is macro level. So depending upon the need of the hospital or the healthcare system, you can choose the method. What method you want to choose depends upon what is the type of problem that you want to look at. So there are 4 different methods. So I hope you got an idea about which one to apply when. So if it is some uncurable diseases like cancer and all that, you can go for the cost utility where the quality of life or the extended year is there. If it's a program like immunization program or investment in a hospital, go for cost benefit. If it's an individual treatment, go for either cost effectiveness analysis or cost minimization analysis. So we are working at St. Philomena's Hospital, myself, and we are running a PharmD program. So this is pharmacoeconomics is one of our areas of research where I guide the students, we work on we apply the cost effectiveness analysis, and then we work on the different treatment options for various diseases like diabetes, asthma, hypertension, and so on. And we help the physicians and we give them the information that which treatment option is most suitable. And we've also contributed to the selection of the medicines for the hospital formulary. And I would say that this is definitely one of the very interesting areas for research. And we as pharmacists, clinical pharmacists, can definitely contribute a lot in by these pharmacoeconomic tools. And with this, I conclude. My heartfelt thanks to the organizers of International Social Pharmacy Workshop for giving me an opportunity to present this workshop, and all of you, especially the 2 of you, for having listened from the beginning. Thank you so much. Thank you.
Thank you very much for a wonderful workshop, overview of the economic budgetary conversation.
So I kept up the time, it's 8:30. I was worried about the time.
Thank you.
Can I take out this?
No, give us one thing, let me just.
Yeah.
In this session.
Bye, Chicago.